We often hear that we only live once, but really we only die once. But in either case, whether we're living or dying, there is something really important that we need to um, behave that way. And it's about a virtue that we all need to have, and we have, but it's really more of one of those virtues that the least known of the virtues, and that is compassion. So a lot of, I mean, our church or all churches, Christianity is associated with compassion. And there is Henry Nouwen who actually has a definition of compassion. There are many definitions, but from a Christian perspective, compassion asks us to go where it hurts, to enter into places of pain, to share in brokenness, fear, confusion, and anguish. And compassion signifies the total immersion in being human. So this is from the book Compassion: A Reflection on the Christian Life. And so the authors say that they place compassion at the heart of a Christian life in a world governed far too long by principles of power and destructive control. Compassion no longer merely an eraser of human mistakes. It is a force of prayer and action, the expression of God's love for us and our love for God and one another. So this is our Christian understanding that we share. However, when I talk to the community, I use this lay definition. We respond with humanity and kindness to each other's pain, distress, anxiety, or need. We search for the things we can do, however small, to give comfort and relieve suffering. We find time for those we serve and work alongside. We do not wait to be asked because we care. So what is missing? We have really missed passion from compassion. Everything around the world, and more so now with everything that's happening in politics, I think compassion is not anymore visible to people, and there's no passion in it anymore. So this is where compassionate communities is about. I mean, it used to be for a long time an aspiration, but now we have proved through evidence that it's a practice. It is inclusive. It doesn't matter what disease you have, where you are from, cultural background. It's committed to system change, and I guess this is, as a researcher, my attraction to it. And it's a key element of public health palliative care approach, meaning that the community needs to be an equal partner with health services to deliver end-of-life care. And so with palliative care, we all know it's a basic human right. I mean, WHO, keep promoting this, but is it accessible to everyone? Not really. Is it accessible everywhere? Not really. Is it still an aspiration, even though we are in Australia, in a developed country? Yes, it is still an aspiration. And I do a lot of research about palliative care, when people are getting it, how in many forms. And unfortunately, it's become more of a service delivery discipline rather than the ethos, the holistic part of how we deliver palliative care, mainly because of funding models and so on. So this is where the internationally models of social and practical support and the end of life are gaining momentum as a result of the compassionate communities movement. But we need a shift in the culture of care and support, care that's more sustainable and affordable. All we hear now is more hospital beds that's needed. And we need high levels of community control and ownership. We need to give back this to the community. So we've gone from aspiration to evidence to practice. And so we know the evidence that only 5% of someone's day, if they are suffering from a life-limiting illness or dying, is spent with a doctor, nurse, or the health professionals that you are part of. And then what happens in the 95% of the day, this is where the informal care and where we spend our time with, friends, families, neighbors, workplaces, faith organizations. So what are we doing to this 95% of people who are in our life? We have actually de-skilled them throughout the decades, basically. This is a national survey we've done in Australia to ask people who actually supports you during bereavement. And as you can see, family, friends, and even funeral providers came really high, probably followed by GP. So we've got only 10% who said they've gone to a professional, counselor, social worker, psychologist, psychiatrist. About 30% said they have gone to healthcare professionals who are not necessarily in the bereavement support, but they are in the community and they can talk to them about their bereavement. If you go to a pharmacist, you might say, tell them my spouse died, like you have those discussions in the community. And really the 60% have gone to informal support networks, which we have, in our life. And of course, as an informal support, the internet is like really growing as such. And I must say, a lot of people don't go anywhere. They are alone as well. So this gave rise to this public health approach for bereavement support, whereby, as I said, 60% were at low risk of developing complicated grief after a loss in their life. 30%, and of course, those 60% usually are dealt with their family, friends, their normal social networks. 30% are at moderate risk, and this is where we need to educate the community more and get more volunteers and peer support for those people to have the time to reflect more on their loss. And only 10% are really at high risk. So when we did this research, we reached a stage where we were told everybody who has a death needs to go and see a counselor. Grief became so pathologized and medicalized, and it was untenable for services to be able to deal with so many people who are grieving. I mean, it's not normal. I mean, grief is part of life, and we've always dealt with it in our communities. And so when we ask people, was the support that you received helpful or unhelpful? As you can see, the blue is where they have been helpful, and the majority were in also family, friends, funeral provider, religious, spiritual advisor. This is why it's really great for faith organizations to be part of this movement in a big way now. And you can see the red is more where there are more professionals, health professionals have been involved. So again, this shows that compassionate communities are alive and thriving, but people are scared now to give help in any particular way. And so when we looked at grief, it's not just a time-limited event in our life. People think that grief slowly gets smaller with time, but in reality, grief stays the same size, but slowly life begins to grow bigger around it. And so that last circle with that empty space behind the red thing this is where the community wraps itself around those grieving people and give them support. And so the body keeps the score, according to Professor Bessel van der Kolk. Social support is not the same as merely being in the presence of others. The critical issue is reciprocity, being truly heard and seen by the people around us, feeling that we are held in someone's mind and heart. For our physiology to come down and heal and grow, we need a visceral feeling of safety. And so no doctor can write a prescription of friendship and love. These are complex and hard-earned capacities. And so the key learnings from this work that we've done in WA that's gone international, the community needs to own a central role in end-of-life and bereavement care with formal professionals advising, supporting, and contributing as required. We need to support the everyday assets in the community who care for the bereaved and who are already involved in the everyday lives of those who are caring and recently bereaved. So these assets is us, the community, family, friends, neighbors, work colleagues. So where did this approach to bereavement support go? Again, it's in our palliative care, our peak body on grief support here in Australia. The Irish Hospice Foundation have developed their practice and policies around this model. The UK Bereavement Alliance in the UK, this is about children's care. Again, they've used this model. The European Care Task Force for Palliative Care have used that. King's College London, particularly with the pioneer of hospice care, Cecily Saunders Institute, the team there have been also following our progress and using it. And everyday health practitioners that I meet in conferences or whatever, they keep saying, thanks for this research. It's really made us organize our resource allocation and know really where to put our efforts and how to develop programs within each of these level of support, the 3-tiered level. And so how are we doing in Australia? The number of Australians dying will double in the next 25 years. This is sort of the baby boomers. So, but many Australians are saying they're not dying in a way, in a place that reflects their values and their choices. and their end-of-life journey is punctuated with avoidable, unwanted admissions to hospital with the confusion, loss of dignity, and loss of control that comes with it. And it doesn't need to be like this in a country like Australia. Professor Alan Callagher said, death is a social event with a medical component, not a medical event with a social component. Unfortunately, this is how it's become in Australia and a lot of the developed world, to the detriment of people, really. Last year, or the year before now, when I was West Australian of the Year, I was asked to write an editorial for the West Australian. And the message I was trying to say to people, it won't kill us to speak openly about death and dying. And I'm sure you may have people like we do in our extended family. If you talk about death in front of them, like they go in panic mode. They feel like it's like a disease they're going to contract and die the following day. So that taboo and the stigma is really something that compassionate communities is trying to break and normalize it, normalize the conversations. So how are we doing in Australia? Dying is increasingly becoming institutionalized. There's 23% increase in the number of palliative care related hospitalizations compared to only 12% increase for all other hospitalizations. And 65% of these palliative care hospitalizations are really dying in the hospital. I mean, the cost to health services is 14 times higher in the last year of life. And the cost is going to get more and more, basically. So when we look at where people are dying in Australia, you can see in every state, this is the orange bar, the majority are in hospital. So, and, you know, we're not going to have enough hospitals for all of us to die in. And as it is now, we don't have the workforce to look after us in our hospitals. So we really need a change of thinking. And it's not something that we can delay and not start working on it now. And certainly I've had those conversations with our state health ministers and the federal minister. And so the reason is that modern death has become cellular, curtained, individualized, and obscure. I mean, apart from priests, I don't think any Australian actually see a dead person because they're either, you know, carted straight from the hospital to funeral provider or from the nursing home to a funeral provider. So that's why people are so scared about talking about death and dying. 70 to 80% of us want to die at home, they say in the survey, but only 14 to 20% do. 75% of Australians haven't had end-of-life discussions. So when they die, their families are totally lost. And they fight amongst each other because they don't know what mom and dad really wanted. And less than 15% of us die with an advanced care directive. And again, this is where the work in death literacy is happening in that space now. Social isolation is going to be the biggest killer in Australia and other developed countries. It's rising immensely. Around 1 in 5 older Australians are socially isolated, and this rises to a third of all the people living in residential aged care facilities. But loneliness is not really in the old. If you look here, the 18 to 24, 38% of them said that, you know, they were feeling lonely. This is despite all the social media and everything that's at their disposal, because people are not meeting people face to face and having that energy flow between, you know, two people when they meet each other. And again, rural and metro are really similar when it comes to social isolation. So social connectedness impact cannot be overlooked. It is a health determinant, whether physical or mental. More people who are more socially connected are happier, physically healthier, and live longer. And the opposite is true. And that was like a large trial that was done. Again, another evidence of that is that the comparative impact of social relationships on reducing mortality is a lot higher than if people reduced their smoking, reduced their blood pressure, looked after their nutrition, did more physical activity, as you can see there. So it's like really powerful determinant of health. And so when we looked at what could be the benefits of creating a compassionate community, it's about building of resilient networks of support around families in need, skilling up the caring networks, increasing neighborhood capacity to care for those who experience death, dying, and loss, integrating and building of trusting relationship with health and social care teams, increasing equity of services, and of course there are financial savings which the health department usually is interested in. So we started in the southwest of Western Australia, Southwest Compassionate Communities Network. And our motto is for every person, every family, every community knows what to do when someone is caring, dying, and grieving. We started with this first lot of lovely ladies with lived experience. Yes, we didn't have any men at this stage. In fact, we didn't have men in general. Just one pastor carer from the Uniting Church joined us later on after this first lot. You can see this is a COVID picture. We all had to stand away from each other because the health service decided this is how it needs to be. So anyway, the connectors undertake network mapping. They go into a family and say, who is your network and how will they respond to your end-of-life care needs? And so they work within those circles of care. You've got the person with the illness and the family carer at the center, and then the inner informal network, the outer informal, the community, and then the health professionals come. So they are essential, but they're not central to the whole picture of end-of-life care. And so the connector enhances those networks around the circles of care. They see who is in the community, who's able to be part of those social networks by offering social and practical support for these families. They call on what we call caring helpers in the community, could be members of the family, friends, or neighbors. And these can do these activities like walking the dog, doing the shopping, collecting prescription, going to the library, or just sitting with a person who needs a break. And you might think these are little things, and certainly our connectors thought that, but this is really important for dying people because it normalizes their life until death comes their way. And these community volunteers are trained to diagnose suffering, not diseases. That's why there's no silos there. Now, when we ask them around all these domains where they need support, as you can see, the majority of them, 76.9%, needed social support. They are so socially isolated. And of course, if you have a life-limiting illness, you tend to become even more socially isolated. And so some of the the help that the connectors source, apart from the, helping people having wills, advanced health directives, the My Aged Care application, the disability stuff, they organize meal delivery, like organizing meal trains, house cleaning, joining community groups like Old Time Dancing, the Men's Shed, surrogate grannies for family with kids. This lady had cancer. She had few kids that needed to go to daycare, but because they bring in all these viruses, then the grannies in the area, help look after those kids. Transport to medical appointment, gardening, social visit. But the most important thing is that empowerment and ownership. You can do this because these people have dropped their bundle and just gave up on life, basically. And so who gave them help? Because half of the patients who were referred from the health service were home alone. They had family, but either in other states or they totally disconnected from them. So we could only find 26% of the help from the naturally occurring networks of those families. But the amazing thing is that 59% came from the external facilitated networks. So people who are not related to them, they were called on by the connectors to come and help, and they were really happy to do that. So a lot of people want to give help, but they are too scared. And the problem is that people who need help are not asking for help. And what we say to those people, it's okay to ask for help because you're not only helping yourself, but you are helping build the capacity of those who want to give you help. Because if they have no one to basically practice on, we are always going to have communities that are not literate in death or grief support. And so we measured this through the increase in social connectedness through a validated model, the validated tool called the Medical Outcomes Study Social Support. And as you can see, the blue one is the post-intervention, and it was an increase in social connectedness that was significant. Then we looked at their needs, which stayed the same between pre and post-intervention, but the availability of support network was twice as much after the intervention because of all this intervention that's happened in the community. Then we asked them to self-report the impact on the social well-being. And the orange one is what the families or the clients, and the connectors are the blue one. As you can see, the reducing social isolation and coping with daily activities came the highest for both the families and the connectors. But the families, but the connectors had underestimated their value, and they were really surprised to see that the small things they've done have really impacted greatly on these peoples in the community. So this would be like a family before the intervention, and who they had around them. And this would be something when the connectors and the caring helpers were part of that system. There's more buzz, there's more talking, there's more, services that are helping. And so, they created all these dynamics for one family. Now, the healthcare usage, again, there were a significant decline in frequency of hospitalizations. When we compared this intervention group to a control group, 63% less admissions, significant decline in the number of hospital days, 77% less days, significant decline in ED presentations, 44% less ED presentation, and significant increased use of outpatient services, twice as much people were going to these services. Why? Because now they have family and friends who love them in the community. So if they feel anxious about their COPD on the weekend, they used to admit themselves to hospital, whether they need it or not. But now they call on these friends, they come and stay with them on the weekend, who help them until Monday, and then they can go to the outpatient services. And then they book their appointments for them and they drive them there. And hence why we've had all these changes, significant changes happening. So the net savings over a 6-month period for 100 patients, 20 connectors and 2 coordinators was on average just over $500,000 in 6 months. Now, does the health service know what to do with these savings? This is another story. Apparently, it goes into center revenue, so they don't know how to claw back this. So this is another story to tell you about that. But this has been quite influential in people replicating this work all over the world. So this is like one of the caring helpers helping the COPD lady do cards for Christmas. This is a multi-generational church group who asked us, how can we help after our Sunday service? And we said, this guy needs gardening. Garden meant so much to him, and he's really going into some depression because he can't really do anything. So they've come and really did all this amazing thing in his garden, and the guy was so grateful. And so what did the families think about the connectors? Always keeps her promises. A lot of paid carers really don't care, just filling in the hours. She goes above and beyond and seems to care. She knew when we were a bit overwhelmed, knew when to get involved and when to step back. I must say we had a training program for the connectors to start off with, and but it's more like to bring them all in the same basically level. But the connectors that actually volunteered already had a good moderate death literacy. And because of their lived experience caring for other people in their family and neighborhood, they were really great to work with, and they knew what to do. Necessary for people who don't have strong existing networks, people who are isolated, it helps open up their world. I can ask her anything, no matter what I talk to her about, she always has a sensible answer. Pretty amazing program. And so this is where the healthcare provider is really positive, especially for clients who are early in their journey and for those who are isolated, don't have good family support. I will be encouraging more people to make use of informal networks and support. She's very socially isolated, and our professional service is not enough to meet her social needs. And so in general, the health services thought it's another string to their bow. And they thought it was easy to implement. The connectors, I think they got the reward themselves from giving as well. And this last quote, the more you give, the better the reward is greater than the effort. I think that summarizes exactly, the experience here. This is when I presented this in Bern at the International Compassion Committee Conference. One of the colleagues from Thailand, he does caricature when he attends a talk, he sort of tries to put it in a form of this. So there's me in my red glasses there. So what is so distinct about this form of volunteering? It exercises more autonomy and have more agency in providing care. It's not like the standard traditional volunteering that we have now in hospital and hospices. It's about sustainable social capital that's emerging from genuine social encounters. It's fresh ways of engaging with the community. So some of the quotes of the connector, it's not a walk in the park like other voluntary positions I've had. It's a whole different level of commitment, but I would do it again. I highly recommend it. It's a lovely way to do volunteer work. If you really enjoy being with people and talking to people, you end up, I don't know, being part of their lives. It's really fulfilling in that respect. So this is about progressing system change. Where are we with this now? We're trying to integrate this as standard practice in health services. We're rolling out to other compassionate communities in WA and Australia through compassionate hugs and community death and grief literacy. GPs are sort of next on the list. We haven't got there yet, but we've worked with local government about developing a compassionate city charter for Bunbury. So I really like this one because that encapsulates what it's all about. You never change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete. And that's exactly what we're trying to do. So with the health services, if we need to maintain system change, we need a change with the way we're doing things. So specialists and generous palliative care, civic organizations, and community networks must collaborate in order to create an effective, affordable, sustainable end-of-life care. And my colleague in Compassionate Communities UK, Dr. Julian Abel, he came with those 4 cogs that really need to work in harmonious. So you've got the specialist, the generalist, the compassionate communities, and the civic program for Compassionate City Charter. They all need to be part of one system that's working well together. Again, here, when we've done our research, it really shows that compassionate communities and social network enhancement is an enabler to integrate all these services on the right who are not integrated, whether disability, aged care, and other ones. And they all need to be around those circles of care. So again, we're looking at more of an integrated model across this figure. So what did we do with local government? We worked with the Bunbury City to create a compassionate Bunbury Charter. And this is to guide and encourage the Bunbury community, including everyone, consumers, service providers, community groups, clubs, to work together to create a more compassionate Bunbury that's resilient, responsive, and understands the need for community support to get through difficult times. And we did quite a lot of focus groups, and we came up with those 10 aspects to grow compassion in Bunbury, from giving and receiving, mobilizing networks of care, respecting people's wishes, again, working with compassionate workplaces. This is all on the website of the Southwest Compassionate Communities Network. And so this really is nested in the Ottawa Charter for Health Promotion about building healthy public policy, creating supportive environment, strengthening community action, developing personal skills, and reorienting healthcare services. And so why do we need a charter? This is really the bigger picture that's going to guide the community. It's a systematic way of ensuring we build compassionate communities in all sectors. We have put in incentive schemes and award at the civic level so that we can reward practical expressions of compassion. And it's a concise way of organizing a purposeful program of civic action oriented towards end-of-life care. Now, was it easy working with local government? No, because they've never really focused on end-of-life care. Public health for them, it's about, environmental care, sewage, water, tarara. So it's been quite good the way we have been able to get them to work with us on this. The community, we're looking at how do we improve the death literacy and grief literacy so that people, if they want to die at home, they're able to do that. And another project is about creating connector hubs, whereby we map the assets of the community, we build the social capital, it's got education and support, and then we have everybody basically connected to this. And we just got funding from Lottery West. This was recently in the West Australian, talking about the how we are rolling out this model across other areas of WA. So I don't know if you've heard about death cafes, compassionate cafes, bereavement cafes. They're all over now, Australia and the world. This is where people go and talk about their experiences, and those who need support and learn from their experiences. Over a cup of coffee, tea, they can chat and learn from each other. We've had a death festival in Bunbury, and where we had one of the features, basically painting or decorating a coffin that was made by our men's shed here. We had an art competition with schools because I think the younger we start with breaking this taboo with the younger people, the better, because I think we've lost hope with the older people. They're too entrenched and rigid with the way they've dealt with this all their life. And I was really impressed when I presented at Zurich at the university there, how many young people were interested in this concept and came and then talked to me after that about starting with Compassionate Zurich, again, Compassionate Bern. Which is great. We also had a WA forum on building connectedness. We're always in the paper. We have something called Dying to Know Day, where we bring the community again to help us with do some events that will improve the death literacy. This is some of our connectors there about reducing social isolation. We have the lanterns to remember our dead, that we write their names around the lantern. We have concerts in the cemetery, which is great. We have them at Father's Day, Mother's Day, so people come in and join in. Compassionate workplaces, we started working with them, how the employers and employees can support each other when somebody is caring, dying, and grieving. We have now the Bunbury giving awards about growing compassion, whether individuals or workplaces or community organizations. This is the first one that he's given to the connectors in this program. By the way, our mayor is the one in shorts, the young one. When I look at him, I feel so old. He's the age of my son. So, and then we have a cooling blanket because some of our multicultural groups would like to keep their loved one at home for a few days. It helps them in their bereavement. Instead of not seeing the person when they die, as I said, they go, from the hospital straight to the funeral provider. So we got a grant to get this cooling blanket, and people, in the community use it for free. Again, we've got really funeral providers with good sense of humor. So they come into our Dying to Know Day, and this time they've made these lovely muffins. Think outside the box. There's lovely saying that I always use, and what I heard it from Walid Ali: the values of death are the ones we should live by. They are truer, a kind of final analysis, freed from the distractions and short-term vanity of our daily lives. And I think if people live by this, I think their life will be better. And so what's happening to our unsustainable aged care system? I'll go quickly here. We're going to spend billions and billions to keep our aged people. And we have a tsunami of aging that we've never experienced before, because people are living longer because they are really sustained well by our wonderful medical system. And so we need an investment of 37 billions, basically. And again, over the next decade, additional investment would be required to furbish what we have now. Add to this another 19 billion. And so I love the way this demographer, Bernard Salt, tried to reimagine life's later years. Many of our oldest and most frail communities are facing death in a perceived state of isolation, anxiety, and depression. And this demands a community response, not a government response. It is unethical, even immoral, to allow the current situation to continue without finding solutions to the coming loneliness epidemic. Outsourcing responsibility for the outcomes of aging to politicians is a cop-out. I love how he's a straight shooter. Aging at scale requires a whole of community response across the electoral cycle. So we've got a freight train heading down towards us. In just 6 years, the first of Australia's baby boomers will turn 85. The number of Australians aged 85 and over will be growing at 60,000 per year by the end of the decade, up from about 20,000. And the latest KPMG report found that by 2050, national demand for palliative care will increase by 200%. This is unsustainable. So he ended by saying, hopefully a calamity can be avoided by a change of approach. And that's what we said. Look, we have one of the approaches that can be used, that's community-led solution with a Compassionate Connector program. Here, what we have achieved, throughout this. So it's just a matter of how do we operationalize it now, in other communities. And as I said, we've just got funding to be able to do this in other communities. And so the secret is not doing to community, for community, with community. It's doing by community if we need something sustainable. And hence, this is what I heard a lot in the year I was West Australian of the Year. I did 65 presentations and media interviews. And I had so many people saying how much there is a gap in bringing compassionate communities to have a seat at the table, to have a national body that can basically bring attention to this if we need to change systems. And so, again, our motto is weaving compassion and connection across Australia as we live, die, grieve, and care for each other. It was great that our WA governor had hosted us in governor's house, which is fantastic. And the lower picture is with some of the board members who are from everywhere in Australia. And so what is it about, this Compassionate Community Australia? And everybody can be part of it. It's building the capacity of compassionate communities across Australia in their endeavors to enable people to care, die, grieve, supported by their community, actively promoting the role of community-based caregiving networks and our collective ability to engage with serious illness and death, and becoming a hub of knowledge and skills for community-led solutions that would lead to social and system change. We just got funding to actually start developing this hub of knowledge and skills. So we have a forum that we are doing in Brisbane in conjunction with the Oceanic Palliative Care Conference. Of course, you are welcome if anybody wants to attend this. It's open to everybody. We'll let everybody know about putting an expression of interest if they want to present or if they want to attend. Usually we put it on LinkedIn. Again, one of the things that we are trying to do is bridge that gap between health professionals and the community, because the health professionals are not bringing the community to be part of caring. And Professor Julian Abel, who's the director of Compassionate Communities UK, he's going to do an online course over 8 weeks, and it's been amazing. We had so many people basically put their name down wanting to do that course. So what are we about? Give a family a fish, it's a charitable act. We're more than that. Teach a family to fish is called sustainability. We need to move on more than that. Organize a community collective, fishing collective. This is about doing social change. And this is where we are at this stage now, with the help of everybody that needs to be in it. And so the final outcome, we need to ensure that when caregiving, dying, and grieving knock at our door, wherever we are and whoever we are, that compassionate support will be found in all aspects of our lives and death.